Well, welcome back to Menders. Today we have Dr. Letitia Anderson. And Letitia, you're a cardiologist. You're also the chief of staff of the new Sierra Medical Center in Northern Nevada. And you're actually a woman of many talents. And among those things, you're the board chair for the Food Bank of Northern Nevada. And fun fact you were just sharing with me, you're also the incoming governor of the state of Nevada for the American College of Cardiology. So I've known you for a couple of years, and I really see you putting your values into action every day. And I'm so thrilled to have you on Menders.
Oh, thank you so much yourself. I'm delighted to be here. I wouldn't have missed it for anything. And also, I wanted to say Happy Heart Month. It's almost Heart Month. And I'm just delighted to be here, spread the word, and chat with you about life here in Northern Nevada.
Awesome. Well, thank you. So you're kind of getting right into it with Heart Month, because that's one of the things that we're going to be touching on today. And I invited you here to think with me about health equity. And obviously you're a cardiologist, you care about cardiac health and the heart, but you're also chief of staff. So we're also thinking about how can we think about health equity for our patients from a systemic perspective, and then equity for employees or the people working in health system. So these are all the things that I'm hoping we're really going to dig into.
100%. I'm right here with you. And I think for me, a lot of us live in that space of health equity, what it is, how we forward these things. When I speak about it to my friends over a cup of coffee or maybe at the cafeteria in the hospital, we might not be talking about that. But to us in healthcare, especially in my field of cardiology or cardiovascular care, we find that these pieces are iterative. And, for me, this concept of hey, I was just at a food bank meeting and we talked about these things that prevent people from getting food security. I was just at a public health meeting about, maybe women in healthcare, maybe even doctors in medicine of different types, and how are they not getting access to the things that they need to perform their careers or even their jobs. And lastly, in a room with my patients, like I know you might be doing, wondering why somebody isn't literally taking their medicine or coming to their appointments and taking that extra, like you said, deep dive into what are these things that are preventing that. And my piece is like, for me in the last 5 to 10 years, you realize, why am I having these same conversations in different rooms with closed doors? And what's really impressive, and I'm such a big fan of living here in Northern Nevada, is hey, everybody's having these collective conversations and the doors are opening. So it's been a really exciting move in the last years, I think, for me and the folks in this space like you.
Oh, thank you. That's a really nice overview. I'm curious, why do you think health equity is a bigger part of the conversation more recently? Why is that more visible as a concern?
I guess I'm based on my age and my demographic, maybe two things. I think it is more visible, like you say. I think we're realizing that despite what we can do, let's take a big picture, multiple $1 trillion of money in our healthcare system in America, and we're not getting anywhere faster. People still die. People still have lives that aren't fulfilling to them and shorter, perhaps. And even if we give them their medicines and get them their doctor's visits, why is it still so bad? And when we look at pieces, like a lot of our studies in cardiology are done, despite these technologies that we've had and we spent lots of money on, we aren't prolonging life in heart disease. In fact, it's still the leading cause of death, even throughout the pandemic, by far. So what is that? And it takes our friends in the other silo of public health to say, guys, maybe it's just because the people aren't at the table, right? Hello, we've been doing this work for years, so why don't we talk about health equity? That is what we call the socioeconomic determinants of health. And there are not that many of them. They come in large buckets, but things like gender, rural access, of course, socioeconomics being financial, or things that are not allowing people to come in, like education or transportation. What we know now, even more diverse things like racial inequities or community inequities, things that simple and that what we call that upstream, that are preventing people from living lives free of heart disease and death.
Yeah. So my early days, actually, I worked in a public health education department at the University of Washington. So training future public health professionals. And I remember at the time being really struck by how much the U.S. spent per capita on healthcare, and then how poor the outcomes were compared to countries that spent much less. And I'm assuming not much has changed, but I mean, can you,
I mean, yes to no, whatever. What you said, yes.
I was going to just say, could you speak to that? Yeah, that's what
Nothing has changed. In fact, sadly enough, the big data kind of popping up again from your sector, Nicola, in public health, is even with COVID, we've had huge setbacks in cardiac health. I mean, we're still way up there. You add numbers up, and 10, 20 years ago, it was the same. We thought we were getting better because we were inventing technologies, stents, better open heart surgeries, more things for symptom-driven treatment. We thought we were making a dent in mortality, but we really weren't. We were making a dent in symptoms. Maybe we're making people's lives better. But you're right. Heart disease is still by far the largest killer. And in our country, even our closest competitors like Japan and the northern countries in Europe are still billions, if not trillions of dollars behind us in cost. And we do not make people live better lives here or longer lives from heart disease. 2/3 of us will die from heart disease if we live to the age of 65 years old.
Wow.
Still, that hasn't changed.
Yeah.
And why is the big thing, not a lot of good reasons.
So are you saying that we're not really digging in and understanding it, or there's just not good reason because we're not giving people an equitable foundation in terms of those social determinants of health so that they are equally cared for?
You betcha. That's the answer. Well, we haven't created many medicines that prolong life or reduce sufferings in my field. And we notice that if we reduce the major causes of heart disease that we know, again, Heart Month, plug, diabetes, obesity, sedentary lifestyle, tobacco use, hypertension, and hypercholesterolemia, things that really, if you know about and don't do anything, you still will reduce your risk of heart disease, simple things like that. And the point that ties into health equity and heart health equity in my field is if you can't have access to education on these pieces because of those socioeconomic determinants, either you're food insecure or you don't have education or you don't simply have access to that education, you will have more incidence of heart disease and stroke.
Yeah.
And what we know too is that if you educate people and they understand this, heart disease, in fact, coronary disease, one of the biggest in the countries, the risk of reduced upwards of 80% per person, huge impact. This isn't cancer screening where, you hope someone gets a mammogram and detect it. This is actually preventing a disease, which is unlike any other risk reduction in the world.
Wow. So figuring out how to prevent disease by changing the environment, providing that education, and then changing those downstream impacts.
Yeah, very small lifts. And this is, again, how it ties back into your life, which you're talking about earlier, is sort of public health. And fast forward to the food bank, I can tell you steps that are very concrete. As the chair of the food bank this year, I've learned more and more about what we're doing at the food bank. Unfortunately, with COVID, numbers are way up here in insecurity of food. We know there that we're serving more than 150,000 meals every month, where a few years ago, that number was probably closer to 100,000 or less. So things are not as good as they were before. We want to put ourselves out of business, both in heart disease and in food banking here in Northern Nevada. But that being said, all of these things are very similar, the same things. What has caused that problem, and how do we sort of focus in on that and make these things less prevalent?
Yeah. So I have a couple of thoughts. My brain is kind of moving in two separate directions, but I'm curious about how health equities impact employees. And I guess I'll just lay out the two things I'm thinking about. Because one, I recognize for myself as a clinician, I imagine for others, seeing health inequity and seeing those long-term outcomes that are so problematic for portions of our patient population, I think that is really challenging or damaging for clinicians. So I'm curious about that. The other thing I'm wondering about and recognizing is that some members of our healthcare community, our employee community, also I think are at risk of being, being in that zone of not having their basic social needs met in terms of safety and housing and good quality food. And so I guess those are kind of my two different thoughts. I'm curious what you think about in terms of, how health inequity is impacting healthcare providers or employees.
That's a great question, and I think we all saw the headlines with COVID. I mean, and there are a lot of sort of topics that are probably brought up in different speakers that you have, but one is sort of feeling comfortable in your space. And I think every provider, particularly I know you and your background, can feel vulnerable, either with a patient at risk who might be coming from a place of fear or anger. You can feel friction with your maybe employer. You can feel friction in the parking lot. I've been to my doctor's parking lot, right? There's all these pieces that add up to a clinician not feeling in a place of safety. And how is that person going to care for another human? And this isn't, a conversation you haven't heard before. How do you feel well enough to give? Where do you feel full enough that you can give from a place of inequity or fear? So yes, oh my goodness, we learned that well in COVID. So I think that being said, I'll go up to like 30,000 feet and say one thing I feel very supported by is my college. So my college, most cardiologists belong to the American College of Cardiology, and they've really come to the plate to say, hey, we're here to represent that safe space. We're here to dig deep. One of their 5 pillars of their strategic plan is health equity, not only for their patients, but for their members. Just sort of where are we coming from as providers? How do we help? One of their biggest topics that I support and endorse and channel all the time is, look, I'm a physician. There are not going to be a lot more physicians. We always talk about that. We need more doctors. Well, let's be honest. I don't know if that's going to be something that I can affect in the next 20 years. But what I can say is I can teach my younger colleagues and my entire staff, as you mentioned, employees, to work as a cohesive care team. And I think a lot of places, I think you're very familiar with Veterans Hospital, I've been impressed with. You come in, every person you touch from the front desk, maybe the parking lot, is part of that care team. Maybe it's the person helping you from your car. That patient experience, we talk about patient moments, and that's one piece of health equity is health moments make up, 5% of the wellness of a patient. The rest is everything else we talked about. Where are they coming from? Where's their community? Where's their family? Where's their access? My moments with my patients when they drive to see me from Winnemucca are like 1% of their wellness, right? So, but their care team approach is a lot. I had a patient call this morning that was great. And she said, hey, my husband has XXX heart condition. Can you see him? And I thought, what are you doing calling me on my cell phone? And then I doubled down and said, this is a healthcare moment. I am going to make a huge impact, right? So I texted my front desk person who promptly, caught the ball, held the ball, passed the ball, right? So if you think of these things, to me, instead of moments, I think of it, I try in my deepest moments to think of it as like the patient as a piece of care being passed along. So that's sort of my care team approach. And a lot of us in our field, at least in our sector of cardiology, like we said, we interface with so many different things. And if you can treat these healthcare moments as a continuum, I think that makes me feel very hopeful and optimistic as a care provider, because that's something you can do. I might just be segmented, but if we work at this, like we do food insecurity, like you do public health, we're all really doing the same thing. Maybe we're doing the same thing at churches in the community or, outreach centers in the community or community centers. Maybe it's all sort of the same process of collective impact.
Yeah, that's so empowering to break it down into those moments. I was interacting with another clinician this morning who I think was really frustrated with a patient and, patient's family, and they were being really demanding and, all of these descriptions of the patient. And it was really interesting because I had a chance to talk with her and kind of break the patient's behavior down. This is someone dealing with a lot, with a new diagnosis that's pretty serious. And what if this guy is just overwhelmed and confused and his family is trying to advocate for him in ways that we perhaps might find frustrating, but that are in a way that, the patient and the family know how. So,
100%.
And it was so powerful to just kind of calm the situation down. It's like, oh, okay, we don't have to start stigmatizing what's going on here. We can just recognize that the patient needs something, they have an unmet need, and then we can be part of meeting that need when we're able to recognize what's really going on.
You bet. And if we had more people like you in this world, we would be so good. But that's what it is. I don't think, maybe we're not trained in that as docs. I certainly wasn't. But maybe as I watch more younger people in my multi-generational workplace, and we're more accepting of this sort of team-based approach, because your feedback to that provider probably broke the cycle. Instead of saying, I fire that patient, or maybe I need the rest of it off. What do we call that in public service? You had a recovery. You recovered the moment. And I think that if I heard that at my minute before impact, I'd say, we got this. Oh, that was hard, but we're here together. And, I just think if we harness that energy, that's where we need to go. I don't think we need more doctors right now in my cardiology world, wherever that is. I think we need more team-based care.
Oh man, I love that. I recently had an administrative department head on. She hasn't been, well, anyway, I'm still waiting for her podcast to publish. But anyway, it was such a powerful conversation because her perspective was, we need more team-based care, and we really need to empower the people who are at the lowest levels of care to kind of reach up and be more integrated into that team, because they have so much to offer and actually have the capacity to take a lot off the physician's plates or even the nurse's plate. And it was such a powerful way for me to think about that, because I think, especially as the provider, the clinician in the room, we can start to feel like everything is on our shoulders, and it's often largely true. But when we can share things, everyone is having a better moment. The patient's getting better care. The physician is feeling more supported. Everyone can just kind of calm down.
Yep. And you know what, for us too, just as you said, if that's coming from the top, saying, hey, we need to support these people, it's a win. I think that's the healthiest piece. You always want to work with the best care teams, but if it's coming from the big boss on either side, either in the C-suite or maybe in the medical field, and we're endorsing and supporting those people, there's a great, cool story that I always think of and I tell the medical students is a big health system that I worked at that was great. And they used to sort of say, here's one of our metrics. It's when a patient comes in with a heart attack, how fast they get from the waiting room to get their stent, right? So we call it door to balloon. And we were killing it and doing great, but we had room for improvement. So the hospital chose to use that metric to sort of see, why can't we do better? What's the best of better, or whatever that is. So they formed like a root cause analysis when you look at things. And they brought everybody in, from the valet guy to the guy in the cafeteria, all these people that had touched the patient at one stop along the road, and the physician was there, et cetera, et cetera. And they looked at a 30,000 foot approach. And the biggest thing they found out was the person that parked the car should be asking the patient why they're there. Oh. And it changed everything. It shaved 20 minutes off. And I still get the goosebumps, right? And it was some kid. He was 19 and he was mortified, right? But they were like, hey, young man, what's the story? He's like, well, no, I just get their keys. And then I say, hey, walk into the ER, and then they check him in. So they said, why don't you it's not a liability. Why don't you just say, hey, nice to meet you. Why are you here? And if they say chest and pain in the same sentence, boom. And that was 10, 15 years ago. Oh. But I thought, oh my God, right? Isn't that the right side of your story? I just thought that was cool.
Oh, that's an amazing story. Honestly, I still have the shivers. But I think one reason that so connects with me, as you know, I work mostly with healthcare leadership teams to take better care of their employees. But it's honestly, it is normally that simple. All I do, I always laugh. I'm like, I do the most mundane things. I just sit down with people and I have the leadership team talk with their employees at every level and get that kind of information. And it's almost always that simple. And sure, sometimes people need big things, but often they don't. They just need these little tiny tweaks to be so much happier. And I mean, it makes a huge difference for quality of patient care and quality for
100%.
workplace.
Yep. Yeah. Yeah. It's, I guess in your field, we call it like people that adapt to the change. And if you bring it that way and the leadership's listening and you sort of have all hands on deck. And I think our next step in our community for me, if I had a crystal ball, I'd love to see that collective impact working amongst health systems, working amongst different church groups, working amongst the community. Where is that forum that we're all sitting there with someone like you saying, hey, what next? And what is our interlocking pieces here that are iterative that we need to be more functional? Is it sort of a multidisciplinary care team? Is it beyond medicine? Is it something that includes, food, healthcare, these things, these different pieces? I think that is the next step, to have innovators coming together and doing these things. And I think we're there, at least here in Northern Nevada.
Oh, that's really remarkable. I mean, can you give an example of where that's already happening or what you're seeing?
Yeah, sure. I think for me, let me give you a good example. I think it's more than 5 years ago at the food bank, through a health center in town and through the different HOPES and CHA, sort of different funded places, nonprofits, they started a prescription pantry, which a prescription pantry, the concept is food is medicine. So the goal of food banks in America, including our food bank, is sort of to have as much healthy, fresh food as we possibly can. Now, that can be difficult. As you know, some people have chickens and eggs can be cheap, but this year eggs hit 50 cents each. Wow. So, I mean, it's been very difficult through the pandemic to supply healthy food, but we've been blessed in this region to be able to do so in a very well manner. So the prescription pantry is a partnership through the different healthcare systems in town, including healthcare systems that serve primarily the underserved. And the concept would be, I'm a diabetic. I get a prescription either through the emergency room or for one of my healthcare centers to fill. And either you go to one of the local pantries here in town and pick up your box with a prescription, to be it for a diabetic or for a person with heart disease. And it's, again, mostly fresh food, but it's sort of engineered directly for you. Now, that sounds cool. And one of the best things that I think the food bank does is they track metrics. And they track, for example, we call them hemoglobin A1Cs. So following the control of diabetes in the patients that subscribe to that program. And the numbers are very good. I think as of a few months ago, they have served more than 30,000 people for sure, even through the pandemic, with the prescription pantry program. So that was very successful. And it hits my cockles of my heart, because it's measuring a metric, it's measuring an outcome, but it's also serving the community. So it's doing, again, the food bank is not looking to stay in business. It's not saying, boy, I wish we had more clients. It's looking to say, can we please put us out of business? So this concept of sort of education, teaching, and sort of, again, back to the health equity lens that we're trying to use. Who are these people that come? And I think that's another piece that we have to dig into. And that's maybe a different topic, but sort of, if I'm one person that gets 5 meals a week versus somebody who just gets one, how do you follow I just told you earlier today, 150,000 meals a month. Well, who are these people? And what boxes are they in? Sometimes it's difficult to track. We can track our prescription pantry, but it's sometimes difficult to track who our clients are.
Wow.
For various reasons.
So how are healthcare systems or hospital systems involved in funding that kind of prescription program, if they are involved at all?
Good question. Here in town, we have a blend of sort of for-profit, either in mental health or in healthcare, and we have non-for-profit of different ways. And some are federally, like the HOPES is moving into a realm also of housing and sort of serving people with extreme health inequities. CHA's mission in the past had been, sort of children, families, et cetera. But all of these places are looking at different funds and different grants. And so I can't say one healthcare system is particularly linked. So these grants tend to be federal and state based, either through systems, so partnering with the food bank or partnering with the healthcare system. But some of what the food bank does, they would have ongoing lots and lots of different grants coming in, but there isn't one partnership that I know of that sort of floats the food bank. I mean, the food bank has a very big footprint in this area and nationally.
Yeah. I mean, I guess you're just getting me to think. So I'm very familiar with large public hospital systems, at least, my home state of Washington, that was a pretty big deal.
I'll say.
So there's a lot of what we call charity care, which is the care that hospital systems write off. And at least in my experience, a lot of that care happened in the emergency room and not in the primary care department.
Yeah.
And I'm sure that that's not, I think a lot of hospital systems experience that. But so hearing you talk about the food bank and the prescription pantry just kind of made me think, like, hospital systems have a financial stake in promoting health equity and in promoting, access to food and nutrition, because this is just my brain and how I think about it. But it's so much more expensive to pay for everything on the back end. So if we're not dealing with inequity, we're going to end up paying for it, eventually, but much more expensive, down the line. And so it's just kind of interesting to think through, like, how our healthcare system really does intersect with some of those basic needs and basic, like, foundational infrastructure supports that help people and stay healthier and stay out of the hospital system.
Yeah. Yeah, I would say speak louder into the microphone, right? It's like, yes. However, when you look at sinners like me who got paid for performance, right? It's sort of cringy, as my kid says, right? It's like, wow, if I see more patients and do more procedures, I can bring a better paycheck home, right? And you hear these brilliant people talking at very high levels about the change from volume to value. Yet it's very difficult when you have a young, upbeat cardiologist, not me, but someone actually young, comes in bright-eyed and bushy-tailed, and he says, or she says, hey, I have a great idea. There are these national guidelines that say we really don't have to be doing this or that test on people. And I could really be saving a lot of money for that patient. And then they get locked in the closet for 10 years, right? Because that is not really helping the hospital, probably, even if it's a nonprofit, probably their bottom line. And like you say, I think I'm still trying to get my head around that. But I think partnering, I have to say, in this town, which I love, partnering with my friends in the insurance companies, partnering with people that are actually sort of foot to the fire, trying to save money. We call that patient lives. I'll tell you a little story. When I moved here a long time ago and I was pregnant, a very long time ago, my very first thing I did, they said, Letitia, you're at the clinic in Fallon. And I said, oh, great. Like, I got my bag and I said, where is Fallon, right? And I've been going to Fallon every week for 16 years now.
Wow.
And I love Fallon, and I know everybody in Fallon, and it's my favorite place. And so, well, I should say one of my favorite places. But that being said, there was a huge debate. Again, when I was bright-eyed and bushy-tailed, I would sit down and say, I love going to Fallon. We should all go to Fallon. In fact, at that point, we had 16 rural clinics, and we had telehealth, all these wonderful things. And finally, I got my head around, oh my goodness, when I'm not at the office, they're losing money, losing patient care days or patient care minutes or whatever word we want to use, very valuable. And I drive out to Fallon. I'm not even worth my gasoline. I'm not going to see as many patients. I'm not doing procedures in the hospital. And it's really hard for me. And I realized we have the numbers. We'd lose millions of dollars at my healthcare system when you have 15 people at different rural clinics. So fast forward through the pandemic, we really have shut down a lot of that rural outreach. And the question is telehealth just as good? Or how do we make these patient moments more valuable? But it's sort of hard. And I think when it comes down to talking to our friends outside of our C-suite and talking to our friends in our insurance suites, and they say, actually, wait a minute, let's talk a different language. Let's talk patient lives and reduction of cost. And like you said a second ago, Nicole, just reducing cost per patient. Now, I'm not talking about, boy, I'm just going to shut the door and not see you anymore. I'm talking about, hey, you're vulnerable. If we have anyone older than 65 in our family, you've heard the phone calls. The insurance companies will call and do a wellness check and say, hey, are you sad? Are you vulnerable? Are you insecure? Asking all of these elemental socioeconomic questions that make me want to start crying because they're so beautiful. Now, I guess I could be cynical and say they're just trying to, save money. Why do I have to talk about pre-authorizations? I just want to do a procedure, right? But when you come to the piece of what I started talking to you about earlier is It's pretty elemental. Heart Month will show you. It's like, please just understand your risk and you'll put me out of business. And I think maybe that's the crystal ball. Again, healthcare is being driven with a co-pilot of health insurance companies that maybe they're not trying to make a profit. Maybe they're trying to help patient wellness. And if we all sort of come to drink that Kool-Aid together, maybe we do speak the same language. And I think that's not a precipice. That sounds kind of scary. Maybe that's the moment we're in right now. That's sort of the go forward, is how do we have that collective impact in healthcare? And I think the key is, you said it right in your first intro, is the key is health equity, because that's where the secret is. It's not a big secret.
Yeah. So, I mean, how do you think we could possibly have hospital systems or healthcare systems go against their own interests, in terms of how they're bringing in funding? I mean, clearly, I guess, big picture, I think we need to totally change how we fund healthcare and figure out how to pay people who are doing the work appropriately and adequately without sacrificing their ability to do a really excellent job or to provide patient care. But how do we help more hospital leaders and maybe more insurance companies value that? How do you help people see that that is really the direction we need to go? Yeah.
Well, if I had the answer, we'd both be really famous and not sitting here probably. But I do think we came pretty close in COVID. They said it a million times, right? Never let a good crisis go to waste, right? That was crucial. And then it was, I'm spacing his name, Ari. He's the big public health guy for Obama. But you shouldn't let it go to waste. And I thought, oh, come on, we're going to get there. We're going to start losing money like crazy and all hands on deck, and they'll come up with some streamlined solution. Not exactly. And unfortunately, I still felt like a lot of healthcare providers of all sorts on the front line were pretty vulnerable. But I do think, even in our lens of cardiology here, I think the fact is, like you said, insurance companies are doing very well making money. I know certain companies made billions of dollars through COVID by the fact that people didn't go or didn't use their healthcare insurance. They stayed home with the door locked. And so I do know hospital systems, you probably read the news this week. I mean, hospital systems are losing money more than ever since the pandemic. And it's not just because we don't have healthcare workers or staff, it's beyond that. So there is sort of a point that I think we need, an inflection point, not for us as healthcare providers or for our patients. I still feel like we'll be still pretty well, at least in my field of cardiology, we'll still have access if we need it. But I think we're getting to the bottom line is, how do we you said it, how do we value patients first off? Because sometimes I don't think we do that. I think that's what these socioeconomic determinants say. We do not value people the same way. Yeah, I call it my judgy. And the second piece I was going to say, and then how do we value our providers? How do you value that guy you helped at your job by saying, don't jump off the cliff. I'm right here. I get it. This person is coming from a place of fear. He is the vulnerable one. And in fact, I say that to patients a lot. I said, hey, the door's closed. It's just me and you. We're on the same page, right? I don't think a lot of that has changed. That provider could say to that patient, hey, I'm having a bad day too, but I'm right here. I got you, because a lot of the stuff that puts us as providers on edge is that sort of being held hostage phenomenon. What is this? I filled out 50 forms and I'm seeing my 75th patient. So I think that piece, it can only be simpler. I really think that.
Yeah. So do you have the miracle solution?
Yeah, I do. No, I don't. But I do think here's what I think, and maybe everyone says this in your podcast, but this is going to be the decade. I mean, think back 10 years ago, you were probably you were probably still in high school, but I wasn't. And don't answer that question. But I had been here so my journey was, I'm from Vermont, I'm from New England, and my husband and I looked around the country and said, where can we go intentionally make an impact? And here we are. And I wouldn't have changed a thing because I didn't live in Seattle. I thought about it for a millisecond, but I was like, this place is huge. I'm going to be on a tidal wave and I'm either going to drown or I'm going to not be important. And I wouldn't say I'm important here, but I certainly feel like care provider can come here and make a difference. I really mean that. So 10 years ago, I had 2 little kids. My husband was home with them, taking care of them. And I was like the luckiest guy in the world. We had just integrated into a huge healthcare system. I was the chief. I thought, wow, I can make so much difference. And I would say fast forward 10 years from 2012 or 2013 to 2023, lots has changed. There's a brand new hospital here in town that's humongous, and they are going to be as big as the healthcare system, the largest healthcare hospital here in town in the next 5 years. And they moved here on purpose because they're a part of a healthcare system, national healthcare system, because this is a rapidly growing area, one of the most rapidly growing areas in the country. And if we see this nationally, they're not here because they want to make a profit. They're here because this is a rapidly growing area. So the fact that they look at people like me, I'm not here to I don't get paid for it, but I'm the chief of staff there. I think because they think, wow, if we get leaders with humility, leaders that are embedded in the community, leaders that actually are here to be ambassadors to say, here's what we do, it's the right thing. So I'm honored to be there. I think by being a leader that's sort of, I guess, there might be a better term of being a leader with humility, or a leader that actually wears a white coat every day and sees patients all the time. I don't get paid to be an administrator. I think that resonates. I think that resonates a lot with healthcare providers. And I love your opinion, but I think it resonates a lot to be sort of a servant. I'm not really a servant, but I'm a provider. What's a better word? I don't know. But if you have someone like that in the driver's seat that's willing to have a co-pilot and 30 co-pilots building by consensus, if we aren't doing that, then I think at our workplace, we got the wrong people in charge. So that's, I guess, my 10 cents about the decade. So this next decade, if that was my sort of flight path for 10 years, and I'm just a local working mom, there's really no reason that all of us can't be doing this and be home at night to hang out with our kids and sit out in the front yard.
Oh, that's just the most beautiful image. I love that. So one thing that I think about a lot, though, is how do we get leaders who are more reflective of the, all the employees? And I think you're really speaking to that, because something I hear often, I lead different conversations with both leaders and clinicians in the same room, and there can be tension or friction that comes up. And I think it's because they're speaking different languages, or because the clinicians see the leaders as, well, you used to be like us and then you let go of your identity. And I think for the folks in administration and leadership, it can be really challenging to try to wear multiple hats and hold on to different loyalties. So I'm curious if you can speak to that, and like how we can just get more on the same page, because I think oftentimes people really have good hearts and want to care for each other, but don't necessarily know how to communicate that.
Yeah, I think you're very well put. I'm pretty opinionated about this, so I'll get on my soapbox for a second and I'll say, you're right. I mean, when I was a kid, we called that being a sellout, right? Or drinking the Kool-Aid, which isn't a very good reference to like a suicide cult, but right. Do you know what I mean? And so, amen. I remember when I said, young, pregnant, and straight out of Vermont, they know that saying, if you're not at the table, you're on the menu. So I was at the meeting, but they said, Letitia, you're such a great leader. I was like, I don't know what you're talking about. I'm pregnant and I'm like 32 years old. So what? And I've never been ambitious. I've never been influenced by, oh, wow, I'll get a badge that says I'm like the boss, because that would be humiliating. I wouldn't even wear that badge. So I think stepping back and looking at myself in the mirror, I always was kind of proud. And I'd say to my partners, I'd say, look, I'm going to go, and I'm not going to be like a spy, but I will go to every meeting and I will be on it and I will be present, and then I'll come back and tell you all about it. So I think that was my impulse. And I'm the youngest of 7. And I know that parents, don't judge me, please, psychology lady, but I am probably a people pleaser. And I think that served me well. And it always gave me warmness and happiness, because I'd say, you guys can put stents in and you can like do open heart surgery, but what I can do, I can go in a room and people really like me, and I'm actually like there to make them understand who we are. But I would not go a step further and either, 1, ask for a lot of administrative time and not be present, or 2, should I use the word sell out again? But whatever, be a different person, I think you said politely. So that I think served me well. And I always thought of that. Now the word I use is I'm here to build consensus with my group. Now, what's interesting about cardiology, and this is sort of another segue, but it sort of speaks to what maybe better than a lot of fields. In 2011, Medicare changed the reimbursement scheme. And they said, cardiology people, this speaks to your value and volume thing. You guys make way too much money. And what we've noticed is you do tons of outpatient testing and you say it's like for the benefit of the patient, but ironically, you're all in private practice and you own all this equipment. And what are you doing? Because none of this makes people live better, longer lives. And we fought for like 2 seconds until we lost the battle. And CMS smartly decided, sort of in layman's terms, to make us not get good reimbursement for outpatient testing. So there's a saying, I don't know if it's true for psychologists or social workers or anything, but they say, if you want to play a game with a doctor, they will just change the rules and then they'll win. So within 2 or 3 years, all the cardiologists in the country, literally even now, it's like 87% of us are employed. So we quickly sold our practices because we were going to go bankrupt anyway. And we made all our patient testing inpatient. So if you've ever had a heart test, or people you know have, they go to the hospital usually to get it done. And even as an outpatient, and they're like, why is my bill $1 million? Well, too bad. It's all monopoly money, right? But everybody knows this. I'm not speaking badly. So we were like, ha, 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 ha. So here we are. And my point was, I understand it pretty good because I've been an employee since that time. And really, I think the Kool-Aid drinking came to the place that all of a sudden you're going to be the chief of your group, which that's easy, right? You come over to my house, you be the chief, we'll have fun, we'll like drink coffee together. But when you're integrated, or that's the word that was used, we used to say when you're eaten up by, a giant healthcare system or a giant corp for that matter, maybe in Seattle. I mean, in where I'm from in New England, these mergers are huge. We know 16 hospital healthcare systems own 80% of testing in patients in the country. So these are huge mergers. All of a sudden, am I going to be ambitious? That's a word from Shakespeare, right? Am I going to be like Caesar and just become an ambitious human? And at that point, what is my soul and who am I speaking for, right? That's, I think, when that rubber hits the road. And we used to say, are you going to protect the badge? Are you going to do anything? That badge says you're the chief or you're the whatever. Is that who you are? Or are you protecting your people, who those people are? I mean, this is outside of patients. This is just corporate stuff, right? I'm not talking really about patients, but that was a big discussion we had amongst our group when we talked about going to rural clinics. All the doctors said, we want to go to rurals. That's why we're in medicine. We had a big discussion in private practice about not taking Medicare patients anymore because we were losing a lot of money. And I remember being a baby and saying, how could you do that? How could you even have this conversation? That's 60% of our patients. And that's why we moved here, because our group had such great ethos and the people that I joined with. And we always talked about that culture and how do you continue that culture along the line, and how do you keep that core? What are the artifacts? What are the moments you use to maintain that culture? And I think if you have, this is just something you do, I know, for a living, but that's the piece. And I think I talked too long on my soapbox, but I would say that burns me, when you come in and you have someone and you say, I think you're in this to do something else, sort of like politics, right? At that point.
Yeah. I don't want to throw anyone under the bus, but I think it's
but you're a safe space.
But it's hard, I think, for people not to let their ego get in the way.
It's very hard
when moving into those spaces. So, do you have practical tips that maybe newer leaders could keep in mind as they are navigating this transition for themselves?
I think, and I totally do. I think I would say one, what's the easiest? Again, it's all about culture, right? You probably wrote a book on this by this point, but we even said at all my retreats that I led, culture eats strategy for lunch. The problem is with a physician. I remember do you know the 9-box approach? It's like when you get, right. So somebody called me in at once and said, you're a leader. We're going to do this 9-box. And they said, I said, what are you talking about? Like, I'm not getting paid, but I'm a pretty good doctor. And my partners love me. And I'm a nice person. So they said, well, where do you want to go in your career? And I was like, I want to be a good doctor. And I couldn't get out of that doctor thing. I just seen a bunch of patients and I was like, I want my patients to be healthy. And they were like, so you really didn't do a good job on this 9 months thing. Like, you're like over here. I don't even know what happened, but I was like, what are you trying to ask me? So what I'm saying is, who are you? And I think we call them white coat leaders. If that's what your institution is looking for, if that's what your job title says. Now, if you're taking a job title, we'll call it, like, for me, it's like a service line administrator. If they want me to be a chief medical officer or a service line administrator, now my job title is going to be pretty different. So I better look at that every day and say, look, I'm here to promote the healthcare system's strategic plan and, build an open heart program. Now, that's what I'm there for. However, if you're there as a clinician leader, and I think that's why the American College of Cardiology is really my happy place, is you're there to sort of build bridges, build health equity, build a home for clinicians. And maybe a lot of our colleges are like that. So back to your question, what do you say to younger leaders? One of my big sisters said that to me when I took a new job. She said, what are you going to do? And I said, I don't know. I'm really excited. There's so much out there. She's like, don't forget to follow the ball. And so that would be my number one as a maybe I'm going to throw a young female leader in to say, what's that ball? Like, what is your joy? And I don't speak to a lot of people. My joy is really easy. Like, I walk out this door, it's sunny. My neighborhood's amazing. I can drive 20 minutes and be all by myself before work, after work. I mean, sorry, it's pretty nice. And so, but I made that joy because I moved here on purpose. So I think that's one piece. And another piece, people are always, and you might have this as well, calling and say, hey, I'm looking for a mentor, or I want to do some research. And I fall asleep, or I go, oh my God, no. And it sounds so, or can I shadow you? Have you heard that? And I'm like, what does that mean? So I tell people, and one of the best advice I got from a friend of mine was, you don't need to ever say yes. Either talk about delegating responsibility and saying, I have 10 friends that you're going to want to meet. And, maybe they're not all in cardiology, but they're in leadership roles, or they are in medical roles, and they're great. Maybe they're not. And maybe they're just awesome humans that have balanced their life well and you're impressed by. But I call that sort of mini mentorship. So, you say, hey, you want to meet for coffee? I'll give you an example. Maybe he'll listen to this, and I think he'd be proud of it. But I had this lovely young college student call me. And I was like, college? I don't even remember college. Like, why are you calling me? And he's like, I really want to be a doctor. I was wondering if I could shadow you. And now I was like, stop it. You don't want to shadow me. You'll be embarrassed and you'll become like a lawyer or something. But I said, here's what I'm going to do. We're going to be best friends, and I am going to point you in different directions, and you're going to come back with feedback. And I said, let's meet for coffee once every other month for a couple years. Even it's a remote coffee. You can text me and say, hey, I'm in Topeka and I'm working in an ambulance or something. But I thought that way I can act as your guardrails. And so I think those moments, one of my doctor friends called me 5 years ago, and she was lulling me into sleep and asked me if I had mentored somebody. And I was like, yeah, whatever. And I got a call from a medical student, and she's like, I'm so glad you agreed to be my lifelong mentor.
Oh,
and I was
wow.
like, what? I don't remember this. And then, because I thought, that's too much. I love these people. So I guess my moments are, create those moments. You can make a huge impact. All of us can, even if you have no titles. You don't even need a title. But if I volunteer up at the medical school, and we have a cardiology group, and we play bocce once in a while, and we have a group meeting, and I invite all these other really cool doctors that are way cooler than me, and half of them aren't even cardiologists. I just say, look at these people and look how happy they are. And so I think those moments, and I still, how much time is that? An hour once a month? So I think that for me is a huge balance and a huge piece. So I think those are how I would say you keep your boots on the ground. I don't think it's genetic. I think some people are ambitious, and they'll realize that, and they will run for mayor, or they'll make steps to get their MBA and become a CEO. And those people are remarkable. And that ambition will get them where they need to be. I don't think I have that gene, but I think you don't need it. And I think there's other pieces that keep you as a leader and have you be more of a humble or a servant leader or somebody that is active in your community. I think that's one thing I would never give up. I think that's why we're here, or at least we being my family.
Oh, it's so clear to me what is meaningful for you and what makes you tick. So, I am curious. I mean, we talked a lot about this earlier, but I mean, how not everyone chooses to do something like volunteering at the food bank in a pretty significant capacity. How does that fit in with you in terms of, what is life-giving and meaningful for you in your work?
Oh, that's cool. I was thinking that you might ask me something like that. And I thought of a story. When I was in college, I was pretty lazy. Like I knew that I wanted to do something, and I went to a really hard college, and I was always angry that we didn't have like a sliding scale or like a pass-fail system. So getting over that piece, I thought, how can I get over here really with like double dipping? Like, what can I take that's going to cover everything? So I said, I've got it. I'm not going to have a minor. I'll have a double major. So like I double majored in like really opposite things. Like I did English and bio, and I was so smart, and I took barely any classes, and I graduated early because I did all these different things. And I thought, I'm so smart. And I think what I thought of, Nicola, when I saw that, I thought you might ask that question, was it's sort of the same thing. Like, when I'm at work and I have excellent friends, Nicole Lamboli is the CEO of the food bank, and the CEO a few people before her was the founder, and her name is Sherry Jameson, and I knew her from the community just from being around. So we used to have coffee dates once in a while. And I said, these people are pretty similar, before I even thought about health equity, like you said, 5-10 years ago. And I said, I come home, I take care of my kids. My husband's kind of got that. So what else can I do? And I can't say I was out there volunteering left and right, but I said right away, what can I do here? And look, I might not be volunteering there and packing boxes on Saturday mornings, but I could do a lot of high level things, either getting them engaged in my healthcare system or working on the board. So I started on the board about almost 6 years ago. And that was the cool part. So that was when I started to say, oh, how do I get other amazing people in my community, more amazing than me for sure, but people in different areas to come here and represent and be, the best, the most solid board, the most wonderful board. So I think to me, that was it. I might not do a lot of things, but I know people who do. So I think that sort of paying it forward piece was pretty easy for me. And again, not a lot of time. I was saying to you off camera earlier, sometimes being on a board is great. Once a month, you walk out of there, you're like, I am so awesome. I'm hung out with all these great people, and I'm going to keep my work going forward. Being the board chair is a lot of lifting, I think, and it's very humbling for me. And I think, again, using consensus, using as many committees as you can, to sort of like spread the load and make sort of more invested people. That was something that I've learned in the last 6 months. But so I think to me, it wasn't like, wow, I'm doing so much more. It was just, wow, I have some talents, and I see these talents overlapping. And by spreading those talents, one in my work, into my spare time, it was very interlocking, as my evidence from college was. So that was sort of my 10-second spiel.
Yeah. And I guess I'm curious if you have anything to say for to clinicians or other healthcare leaders about why it might matter to them, or just help them to feel like more whole people to be involved in something like that that's so deeply meaningful, but that isn't their work per se.
Yes, 100%. And I think I see the piece you're going to, and it's something near and dear to you or my hearts, I think, is that wellness piece. I am sure, I don't live in this space, but I'm sure studies from your fields would point to the fact that people that feel fulfilled live better, healthier, weller lives, free from sadness, free from, not feeling fulfilled, I think. And I always carried that with me. I thought, geez, I should really go and like volunteer or join a church, or why don't I take more time off and go skiing? What am I actually doing? And somebody finally said, you're doing a lot. And I said, yeah, I am, and so in and out of work. So let me answer the question by providing another scenario. I had this amazing young resident who is come to be a good friend of mine, and he has delighted to go into cardiology. And like a lot of people said, he called me and he said, can you help me get into some research? And again, I had that moment of like, no, I can't. You don't need research. And I said, look in the mirror. What are you doing? He said, well, I'm doing a lot with the younger people. I'm going out to this. I'm doing all these things. And I'm working at the VA and I'm working at all these different hospitals in town. And I said, you're killing it. You're bringing it home. Like, what do you mean you need research? And he said, well, to get into a good fellowship for cardiology, I probably still need research. And I said, I defy that norm. That is not true. And when I said I want to be the governor of my college for cardiology, I sort of went to the edge and I said, hey, I'm a underrepresented minority, being a woman, being out here in a rural state. And you know what? I'm going to step up to the plate and say, yeah, like I am. And unbeknownst to me, everyone else was stepping up to the plate and saying the same thing. So I said, how about you come out with me and we'll either go to the School of Public Health or we'll go to the food bank and we'll talk about grants and we'll talk about outreach and we'll talk about underserved people and backtrack to the things we've just been talking about. And why is that not your research? We talk about pick a socioeconomic determinant of health, hop onto a bandwagon, either with one of these amazing institutions out here and publish a paper. Like that's research, and you're actually doing something that's amazing. And, he took it and ran. And so I said, this is amazing. And of course, everyone at the food bank said, there's a real doctor coming out here who wants to what? And you're like, I win. So that was like 4 texts. He didn't actually start crying or anything, but he sent me like a big thumbs up emojis and stuff. So that to me, and I'm sure places like Seattle and all these other wonderful places have done this in spades. But for us in Northern Nevada, I said, that is like that one step at a time piece. And I thought, if this young man goes on to get into his fellowship, which he will, right, and say, hey, his patient says to him, how did you get into your fellowship? He says, well, I cared about, or whatever, just make something up, our underserved population of X, Y, and Z, and I put together some data, and I realized, surprise, surprise, hunger is a problem in heart disease. Like, here's your silver platter, right? So that to me, if that's not that story isn't sort of a sentinel piece of wellness, it was my wellness, but that young person said, you got to be kidding. This is going to be fun and easy. And I'm maybe not sitting at shadowing someone or researching with someone or those painful things I think all of us went through just to check those boxes. So that's sort of my sentence. And I think in Northern Nevada, we're all just one phone call or one text away from that.
Oh, that's beautiful. And I'm laughing because I had a meeting with some of my students today and they were, I think, similarly trying to get a big publication out and all these things. And we just had a conversation like, well, what would it look like if you reached out to like a small publication or a publication that is for humans or regular healthcare clinicians and you shared your message with them and they were like, oh, I never thought about that. And it was just such a beautiful moment because, they can bring their passion. And I think, publications are great. I have them, but, go so much farther to connect with people and offer value right now.
100%. And I put the lens back onto you and these small, and I didn't have so many friends on my tiny little social media site. And I just want to give high fives to so many people who are out there cringingly maybe promoting themselves or what they do or a friend. It's just, who knew, and back to this cool decade that we have. I have so many doctors that I think don't really want to do it, but they're out there saying, hey, I'm humbled to do this. And what a collective impact that is, at least for our small community. So I appreciate you because you live in that space.
Well, thank you.
Being awesome. Yeah.
Well, I am honored. Oh man. Well, this time has flown by so fast. So I just want to know, is there anything else that you want to share? Any last thoughts you'd like to leave the Menders community with?
I hope, and I listened to your very beginning, I think I'd hope, Nicola, that we have lots of young, dynamic, well, younger than me, I'm going to use that broadly, 50 and below, because I believe so strongly, not just in that culture piece, but in that multi-generational piece. And you spoke to it a little bit when you said something like every single level of the pyramid needs to be engaged. And I have such huge open-armed hope for our generation in the next decade looking and working for young, beautiful people that are in our post-millennial and Gen Z generation, because I think that's what we're doing. In the words of my child, who was 14, he said one day, I said, "You're going to save the world." And he said, "Well, I didn't mess it up." And I said, "Okay, good point." But I think what I'm saying in English is not just in medicine, but in all of these fields. I'm just so enthusiastic, at least in our small community in Northern Nevada, that we have so much in this next decade to look forward to.
Oh, that's beautiful. Thank you. Thank you so much for sharing that.
No problem. I have a T-shirt you can have. It says, you know that saying, "Kids these days," and it says, "Kids these days will save the world."
Man,
which I like.
I mean, that's what I'm counting on. My almost 4-year-old, she's already taking over the world, so she's definitely going to save it.
She'll do it. I believe it. I believe she will. Thank you.